thank you all for jumping onto this new time. I thought when I realised the oral timing this weekend, I thought maybe we could just fit one in today. Unfortunately, Anna can't join us, so she sends her apologies. So I'm sorry you've got a non-specialist today. You've got me and me. So I hope it's fun, and I'm glad we can get one more session in.
Oh,
Um,
thank you. Yeah, thank you so much for doing that.
so Jeff, please feel free to jump in and help if I miss anything or any comments that you have.
Helen, I don't think that's likely to happen.
Yeah. Yeah, but I've watched quite a few of your tutorials now, Helen. So
Are you doing your fellowship this year, Helen?
Oh, no, I don't think I'm going to, Jeff. Anna keeps trying to talk me into it, but I love my job and I feel like I'm in this beautiful mix between Anna's amazing specialist brain and being there for our GPs. So I think I'm going to stay like this, I think.
That is, I think that's a mistake, Helen.
Oh, do you?
Yeah,
Okay.
I'd go for
That's
it. Remember, Sir Edmund Hillary climbed mountains because they were there.
good advice. I'll have a think about it.
Yeah, I mean, and don't expect to get it the first time.
Yeah, no, yeah, that's true.
Um,
And
and
that's true for members too. If you guys, if you don't get the result you're hoping for this year, we won't talk like that, but there's um there's always next year when you're really prepared because sometimes it's overwhelming how uh not knowing what to expect, whereas you like know what to expect next year. Alrighty. So I thought ignore the numbers because I've changed the order a little bit. I thought we could do a few cases that I hope we haven't touched on these topics. If we're getting to the end and there's any topics anyone wants to chat about, then also feel free and we can be flexible. Okay, first case. An 8-year-old female spayed golden retriever presents for being off color. She is taking longer to finish her meals, and the owner has noticed exaggerated swallowing. On exam, her left pupil is myotic with enophthalmos of her left eye and protrusion of her third eyelid. Give your rationale for each diagnostic test you wish to perform. Would anyone like to have a go?
I think I'd CT the head.
Yeah,
And the basis for that is more will be missed because she didn't look than through not knowing what's in the book. And the CT will pick up a lot. Enophthalmos of the left eye. Um,
Mm.
just trying to think what can cause that. Perhaps the more knowledgeable membership candidates could remind me of what causes enophthalmos.
uh, I think is it central vestibular disease will cause it. Um,
so if we put those three together, if you've
yeah.
got a myotic pupil,
So it's smaller than normal.
smaller than normal,
Yeah.
enophthalmos,
That's your Horners, isn't it?
yeah,
Yeah.
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 Cool.
your
Mhm.
eyes shrunken away and protrusion of your third eyelid. So they're quite classic of Horner's.
Mm.
Which nervous system does that mean is has been interrupted?
Peripheral nervous system. The sympathetic nervous system.
Yeah, perfect. So if you think the way I like to remember it is if you remember back to vet school when you were learning about parasympathetic and sympathetic nervous system, you're going to need your pupil to dilate so that you can see as much as possible, as much light is getting into the eye. So Horder's is when your sympathetic nervous system has been disrupted. So this patient either has parasympathetic nervous system activated or sympathetic nervous system disrupted. So put with the other findings of the enophthalmos and the protrusion is classic of Horner's, which is sympathetic nervous system disruption.
I should have mentioned that. I mean, when I was practicing as a specialist, as soon as anything arrived, it was full bloods and urine together.
Yeah, beautiful. So we're going to start with that. Each diagnostic test, let's start with full bloods and urine. Does anyone want to give any rationale, if that was the question for that? I mean, you're going to say that in every case, but
You're just screening like the general health of the dog, trying to see if there's any clues to what's going on, like a elevated white blood cell count that might
Perfect.
inflammation or infection, or cancer. And then your biochemistry again, just like looking at liver, kidney function, just any clues or any comorbidities that the dog's got going on. And the same with the urinalysis, again, checking kidney function or any increase in your proteinuria or anything like that that could indicate anything. I'd also do a neurological exam on the dog to look for any, like trying to localize any further, like because your sympathetic pathway is quite long, goes from your brainstem down to your thoracic cavity and then back up your thoracic inlet, back through the middle ear into the eye. So, if you have other cranial nerves affected, maybe it's more of a brainstem lesion. And I'll do an ophthalmic exam and also look down the ears as well. And then a CT, probably head, chest.
What would you CT? What areas? I said only the skull, but I realised I made a mistake.
Yeah, so I do head, chest because the sympathetic pathway goes all the way down to the thoracic cavity.
Which thoracic units or vertebrae does it originate? T what numbers?
I thought it was T2, T3, but somewhere around there.
Yeah, that's right. I thought it was 1, 2, 3, but Helen would know better.
1, 2, 3. Yeah, I think they're great. Great testing grids. So just remembering that obviously our neurological exam, ophthalmic exam are going to be really important, but head, neck, and chest CT, because if you remember, there's the 3 orders of Horner's. So like Ingrid said, first order being central, second order being it's running preganglionic, and third order, like Ingrid said, checking middle ear disease as your nerves run from your brainstem down your thoracic cavity and then back up and cross close to the ear. There's one other test we could chat about, or two, just briefly. Does anyone have anything else they want to do?
Could you potentially do survey radiographs of the head and neck to check for megaesophagus?
Yep.
And following on to that, I'd probably consider video fluoroscopy to check if that swallowing mechanism is functioning properly.
Yeah, so we can definitely say radiographs and thoracic radiographs as well, actually.
You could get up with a CT if you just remind me what the innervation of the esophagus is.
Oh,
For the vagus nerve?
yeah.
It's,
Or is it their laryngopharyngeal or something? Or is
doesn't the recurrent laryngeal idea, look, I've forgotten this, but a third of it is one nerve and then the remaining 2/3 is another. I've seen 2 cases where a barium study showed that distinction. I'm sorry, I'm a bit rusty on just what was where, and
It's interesting. Yeah, that's interesting, the different nerves. Yeah.
So is there I can't remember the name of it, but you put a drop in the eye
Yes.
and then it will make it, then you can figure out if it's like a first or second one. And I can't quite remember how it does it, but like, because the affected eye is the constricted eye.
Yeah.
And then you put it in and see if it's going to make any difference within like 20 minutes, whether it dilates or not.
Yeah.
But I think it starts with P. I can't remember the name of the drug though.
Does anyone want to expand on that?
There was definitely, I could be wrong, but there was something about cocaine drops. I don't know.
So we don't use cocaine drops anymore, but you're exactly right. So you can use phenylephrine drops because you just need something that's going to mimic the sympathetic nervous system.
So if you were to say is it sympathomimetic?
Yeah, sympathomimetic. Yeah. Drug, and cocaine is one of those. So you put a drop into the eye, and the difference is that if you've got first order or second order, the pupil is going to take quite a long time to dilate, so over 20 minutes, because you're trying to mimic your sympathetic nervous system. But with Horner's, we know that the sympathetic nervous system is being disrupted. So the nerve is being disrupted to dysfunction somewhere along its route, from brain down to thorax, back up to eye. With third order, which is the problem closest towards the eye. I should have had a little diagram. It will dilate really rapidly. And that's because you've got essentially upregulation of the nerves at the back of the eye that have been deprived of that signal for so long. They dilate. It dilates really rapidly with third order. I don't know if I've explained that properly. Denervation hypersensitivity is the term.
So if you've got third order, you're going to get very rapid dilation.
Yeah.
And third order, it's closest to the brainstem.
No, the opposite way.
Sorry. Yeah.
Brain is always
More
number one.
peripheral.
So central is first order. Then preganglionic is second order down your thorax, and then closest to the eye is third order.
Just something coming out of my rusty neurons at the back. Examination of the eye in the dark or in bright and in bright light. Now, what does that do?
So that's we're going to know whether that pupil has the ability to constrict or contract appropriately to its environment.
I think I remember something about that too, Jeff, and I read something where, the light and dark helps you decide whether it's one thing over the other, but I can't remember.
Sometimes it's hard. It sounds silly, but sometimes it's hard to tell if the myotic pupil is the myotic pupil or the normal pupil, and the other one is dilated or the normal pupil, if that makes sense. So in this case, it would be quite obvious because we've got enophthalmos and protrusion of her third eyelid. So we'd probably know that that's the myotic pupil. But sometimes you might look at a pupil that looks myotic if you've got disparity in your pupil size, and it can actually be hard to tell which one is myotic and which one is dilated. And so the dark and light will help you figure out which one is responding appropriately to the ambient light and which one is pathological.
Yeah.
Because it's only a small anoscoria, that's what it's called, isn't it? Then it's not as obvious.
Yeah, the in the dark, obviously they're going to dilate. You're testing for dilation, which is parasympathetic, and then in the bright light, you're testing for constriction.
Okay, great.
The other way around. You're testing for constriction in the bright light.
Yeah. You perform thoracic radiographs. Interpret and assess these radiographs.
Is there more than one?
There is. You ready? I'm gonna flick between the two. And if an examiner shows you these, you can ask to flick between the two as much as you like.
It looks like there's like enlargement in the cranial mediastinum, an increased soft tissue opacity in the cranial ventral thorax, which will be in the mediastinum, but it's just on the lateral view.
Yeah.
Heart's elevated off the sternum as well. And there's some. How old was this dog?
8.
Yeah, so there's some parrot beaking in both the sternum and the spine. But the other view, the VD, is not a very good X-ray because you can't, the spine's not defined. And the right scapula is over the chest, whereas the left one is
I agree.
a bit out. So
Not super straight.
that's why I like CTs over X-rays.
So increased soft tissue opacity in the cranioventral thoracic region, possibly corresponding with, is it the cranial lung lobe? Right. Yeah.
There's some other object down there in the front of the sternum, like in the cranial aspect of the sternum. Now, what the hell was that?
Where do you mean, Jeff? Can you see my
Yeah,
cursor?
down there. Yes,
So I think probably a lymph node.
that's right.
Yeah, so great. So, like Ingrid said, and I know this sounds really silly, but it's tempting to go to the most obvious thing. But like we've done before in these tutorials, just kind of giving a little bit of an overview, just so you don't miss anything, is also helpful. So, take as long as you need when the examiner presents the X-ray. Don't rush to say anything if you don't want to. Just think for a minute, have a good look around. I'm sure you've all got your own approach. What I typically do is would say something like, okay, we're presented with a right lateral thoracic radiograph and a VD thoracic a DV rather, thoracic radiograph, they'll tell you. And then use your normal approach so that you don't miss anything. So I kind of do the circle approach, going outwards in. I'm sure everybody has the same. And so even things that you don't aren't necessarily relevant to the case, it's good to talk through. So we can definitely jump to the big increased opacity, as you guys correctly said, in that space consistent with the cranial mediastinum. The cardiac silhouette is elevated off of the sternum. We've got increased opacity in this ventral thorax. We can also comment the visible lung lobes. I've cut them off here, sorry. You can also comment on what you think about the lung nodes. We can say we've got a nice intact diaphragm. We can say the visible vertebrae appear normal. Whoopsie. We can say there's very mild deviation of the trachea, but the width is uniform, just so that we're kind of commenting on all the major structures in there so we don't miss anything. Okay, beautiful. It's a nice obvious radiograph. I hope you get something like that in your exam. Give your leading differentials for this patient and outline the next diagnostic tests that you wish to perform.
My leading ones would be like thymoma or lymphoma
Perfect.
in this patient. Like ideally I'd do a CT of the chest cavity, and then I would sample it. So I'd do ultrasound guided fine needle aspirate. You could also do like a TrueCut biopsy, but I'd probably start with fine needle aspirate for cytology. And then you can also do, I think you can do flow cytology as well. Like if there was, if it came back as lymphoma, then do flow or immunocytochemistry. So you know if it's B cell or T cell. I think those are the main tests I'll do.
What's a limitation of fine needle aspirates of a cranial mediastinal mass?
You might not get a diagnosis, like you might not get enough cells if it doesn't want to exfoliate. You can't do crating and stuff, but you don't really do that with lymphoma anyway. And usually lymphoma does exfoliate pretty well.
I think you can do, it's not staging, but you can do I think it's immunocytochemistry on cytology for lymphoma.
So one big limitation of aspirating thymomas is that over half of them, pathologists won't be able to call on fine needle aspirates, annoyingly, because they have a really like complex mixed population and often have a lot of small lymphocytes that the pathologist can't call lymphoma or thymoma. So it's a really good place to start as non-invasive, but like Ingrid said, an ultrasound guided TrueCut or core biopsy sounds really scary, but is often needed for diagnosis. Any other differentials? So thymoma, lymphoma, absolutely, like we said, are going to be our leading differentials. Anything else that anyone wants to put on a differential list?
Like a coagulopathy or something? Like, is it? Mind you, it would be pale and stuff, I suppose.
Yeah, you might have picked that up on the full blood count, but you did to start with.
Yeah.
So I think that's thymoma and lymphoma are definitely what we're going for. Other things that we could see there would be like ectopic thyroid tissue, or carcinoma, or chemodectoma as well in that region. We'll see.
What about post-operative? If you do a TrueCut biopsy, for instance, is there any particular post-operative care that you'd be interested in?
Just monitoring. So you can just do serial POCUS thoracic ultrasounds to monitor for hemorrhage.
And well, respiration rate, which you can get
Yeah.
from without even opening the
Absolutely.
cage,
Absolutely.
because quite a high percentage of them can develop pneumothorax.
Mm.
About a third was my understanding, but I guess in your capable hands, it might be less than that.
Yeah, it's definitely a risk, but hopefully self-limiting rather than requiring intervention would be the hope. I'm just going to touch on a couple of other things here quickly. Is there any other diagnostics that anyone can think about if thymoma is our leading differential here? Actually, I say that, not just thymoma, lymphoma too. So has anyone heard about thymomas being able to cause myasthenia gravis paraneoplastically?
Oh,
Does that ring a bell?
yes.
Yeah.
I
So
did have myasthenia gravis on my differentials list.
yeah, great. So because
Yeah.
mentioned at the start, notices, I know it's hard because I haven't got that on every slide, exaggerated swallowing. That could absolutely be due to the cranial mediastinal mass. And we can see the outline of the esophagus here, but also just discussing, I think would be an important point here, quite a high percent, so about 40% of dogs with thymomas will have paraneoplastic myasthenia gravis. So does anyone want to tell me about if we would do any diagnostic tests or what we would do just with that in mind?
You do the acetylcholine antibody.
Yeah.
And could you do the acetylcholine esterase and test as well?
Yeah. Yeah. So we're going to do the antibody test, probably is going to be the most accessible. Great.
I think
Right, like
acetylcholinesterase has to go to America, doesn't it?
Mm.
Isn't there another drug test that you can do?
Yeah, sure. Is that not an acetylcholine esterase?
Yeah.
Like, I know there's the antibody test, but there's also, oh my God, I
Do you know
forgot.
what it's called?
Uh,
One that's, we've got
Peronostigmine or something, isn't it?
Oh, yeah.
And you
That's
can give
right.
it and see if they get better. But that would be if it was showing other signs of myasthenia gravis, like, because I know they used to use that as a test or something, then they would start walking better and yeah.
so
Lansoprazole is the better drug for that,
we've got
but you can't get it. So the thing with the neostigmine test, there's a protocol written by which includes giving atropine first. Why would that be? Why would you give atropine first?
So you don't get overstimulation of the sympathetic nervous system?
What does atropine block?
it's a cholinergic crisis.
Yeah.
So because neostigmine, which is the drug that we would use for the test, is going to stimulate our parasympathetic nervous system, it can cause quite significant bradycardia. So atropine is going to protect your patient from that, giving it first. So
What does atropine block?
Does anyone know the mechanism of atropine?
It's an anticholinergic.
Yeah, but where?
Just blocking your parasympathetic nervous system, right?
Yeah, but which parts? Is it ganglionic or postganglionic or neuromuscular junction? Just put that down as a question with notice.
Sure.
Because I think it's important to understand those neuroactive drugs on the parasympathetic and sympathetic nervous systems and where they actually work, because knowing the actions of other poisons like organophosphates, which you don't see much now, but I've seen heaps of it. Just knowing how they work and how to stop them.
Okay, I just looked it up on plums, and it inhibits acetylcholine or other cholinergic stimulants at the postganglionic parasympathetic neuroeffector sites.
Yep.
Postganglionic.
Good on you.
So we can test for myasthenia gravis. What else? What other paraneoplastic things might we see with lymphoma and thymoma that we should potentially look at?
Hypercalcemia.
Perfect. Yeah, hypercalcemia for sure.
You also run parathyroid related peptide. Parathyroid hormone related peptide.
Perfect.
This one.
And would you expect that to be high or low with paraneoplastic?
High.
And what would you expect the PTH to do?
PTH, would it be low
Yes.
because of the hypercalcemia? So you're getting that negative feedback loop.
Perfect. So we can run an ionized calcium because we might not have done that in our baseline bloods. We can run a PTH, PTRH as well. And what about if we think if we're not sure? So say we've done our CT, we've confirmed that there's a mass there. We've done a thoracic CT. Is there any other imaging that might be helpful based on those differentials?
You might want to do an abdominal ultrasound or a CT of the abdomen as well, just making sure there's not lymphoma or anywhere else.
Perfect. Yeah, absolutely. Yeah. CT, abdominal CT or abdominal ultrasound. And you could even do a dual cavity. You could do an echo as well, just because we had chemodectoma on the list. It wouldn't be wrong to. Great. Okay. So we've done quite a lot of diagnostics. A thymoma is confirmed. What is the recommended treatment and prognosis?
Ideally, surgically remove it.
Yep. Perfect.
Is it easy to do?
Pardon, Jeff?
Is it easy to do that?
Oh, I don't know. I've never surgically removed one. I wouldn't
surgeon
imagine
either,
so, but I'm sure for a specialist surgeon, they'd say, yeah.
Oh, they do, yeah, but they can get around all sorts of other structures, and they
Right.
can be a real bathtub to get out sometimes.
I work for an oncology practice, and I've been asked to write a paper on cat thymomas
Ooh.
for radiation. So we're seeing very similar median survival times for thymomas with radiation, but it's not published on, so I don't know if I can talk about it in an exam.
That's exciting. Would you like to share the prognosis that you tell owners with the group?
We've been getting about 12 months, and it depends on, so sometimes we follow up with chemo as well. It just depends on response rates, but yeah, I think we've been saying about 9 to 12 months with radiation.
Great. That's quite good. And do you guys know if your patient has got myasthenia gravis, a paraneoplastic form, will that affect the patient for the rest of its life? What's the prognosis of that? If the patient has the thymoma surgically removed, sorry.
I figured it would come right because the source of the paraneoplastic has gone away.
Perfect.
So it sorted itself out. Yeah.
Yeah. So it doesn't actually impact survival time, but it would potentially impact morbidity and potentially mortality around the time of surgery because you're going to have the secondary complications of myasthenia gravis, so aspiration pneumonia, etc. Great.
How do you manage a myasthenic dog? It's got esophageal megaesophagus.
So Olivia, I think you already said the medication today.
Yeah, parastigmine or something. I have trouble saying it there.
Pyridostigmine. Yeah.
Yes, that's it.
Yeah.
Yeah. And then that's trying to, it binds to, because there's these little enzymes that clean up all the acetylcholine, I think, in that neurojunction, and so it binds to that to stop it mopping them all up. So then there's heaps and heaps of acetylcholine in there. So any little receptor that's available will just bind to it and get through. That's
Yeah.
What's a Bailey chair?
what was that? Sorry.
What is a Bailey chair?
Oh, that's the cool little chair that they sit in to eat, and you keep them in that like about 15 minutes after they're eating, so that everything stays up and doesn't go into the big esophagus, the megaesophagus.
So the gravity feeds the stomach,
Yeah.
because the esophagus can't push it down. And what's the prognosis of a myasthenic megaesophagus?
Depends what the underlying cause is.
Yeah, and how long it's been there, I suppose. Yeah.
Yeah, they usually end up with inhalation pneumonia. They often peg out within a year or so.
Yeah, they can. Yeah, prognosis we typically say like about 18 months, but some of them just spontaneously get better as well.
Yeah.
Interesting. Yeah. Okay, great. Next case. You are presented with an 8-year-old Meldee-Sex Cocker Spaniel with a several-week history of tiring easily on walks. Today, he collapsed on a walk with laboured breathing. On exam, he is quiet in mentation, standing with his neck extended, with a breathing rate of 60 breaths per minute, increased effort and a heart rate of 132, synchronous but reduced pulse quality. His rectal temperature is 36.9. Outline a problem list for this patient and justify initial diagnostic tests you wish to perform. Would anyone like to have a go?
Well, is it respiratory or cardiac? It tells you there in the information you've got in green.
So the problem list questions are quite nice because they're nice, easy marks. So we can actually just go through and list out. So we can say more chronic, tiring on walks, acute collapse. We can say tachypnea and dyspnea. We can say altered breathing position with his neck extended. We can say tachycardia, reduced pulse quality, and mild hypothermia for a problem list. Are we all happy with that?
He's not really tachycardic though, is he?
I think I'd probably say 132 is a bit tachycardic, but it's a good point. It's not marked.
If it was cardiac in origin, I'd expect a heart rate much faster than that.
Yeah, that's a very good point, actually.
That was the basis behind the question I asked first.
Oh, well, this is my poor writing of a case then, because I'm going to lead you astray if you go on that.
If the heart rate's low and the respiration rate's up, it's probably respiratory and not cardiac. Whereas if the heart rate's really fast, really tachycardic, it's more likely to be a cardiac origin, but it could be both.
So with that problem list, does anyone want to say what initial diagnostic tests they wish to perform? And we can do nice, easy marks, the simple things first.
I was just going to ask, sorry, would you say that was hypothermic, but cold? Like, did you add that to your problem list?
Yeah, we had that on the end. Yeah,
okay.
I would.
Yeah.
So can I have a go?
Yeah, go.
Yes. All right. So I would start with, probably some oxygen supplementation. I'd start with a minimum database, which would include a CBC, biochemistry, thyroid exam, and urinalysis. I would do a PCOS of the thorax and the heart to look for signs of pleural effusion, pericardial effusion, and possibly pneumothorax as well. I think that's what I would start with first. And if we were stable enough, I'd then consider doing some abdominal and chest x-rays.
That sounds perfect. Yeah. Does anyone want to add anything? That was a great answer.
The blood pressure would be good too.
Perfect. Love that. Why do you say blood pressure specifically for this case?
Reduced pulse quality.
Perfect. Yeah. Great. Yeah, perfect. We could do, and it's not wrong to add in, you'll get a lot of marks for all of those. It's not wrong to add in other things as you like, but not absolutely necessary, like an SpO2, a blood gas, an ECG, but those initial things are perfect. Great.
Remember in your initial physical exam, a lot of those things you should pick up. Like with auscultation and percussion of the chest, you might have an idea whether it's pneumothorax or whether it's fluid in there.
Yeah.
Lymph nodes, are they up? and the heart, is the heartbeat regular? Any murmurs? All those sorts of things. More will be missed because she didn't look than through not knowing what's in the book. And the physical exam's much cheaper than a lot of these other tests.
So true. As part of your diagnostic workup, you perform an echocardiogram and confirm dilated cardiomyopathy. CBC, baseline biochemistry, electrolytes, and urinalysis are unremarkable. List and justify any further diagnostic tests you would perform on this patient with confirmed DCM as part of a comprehensive approach to the disease. Is there anything else you would like to ask the owner in this patient's history? I'll give you a clue. You already said one earlier about after your minute about when you said CBC, biochem, and something else.
I would do thyroid level.
Perfect.
Taurine testing, ECG, Holter, and get a diet history from the owner.
Perfect. And if I can be mean, what can you expand on thyroid level a little bit more? What would you like to do?
Total T4 to start with, and then only do the other tests if it's indicated if you have a low T4.
Great. And what other tests? Say your total T4 came back as 10. What other tests would you do?
I could do a free T4 and a TSH.
Perfect.
What about TSH? Is that any help?
Yeah. So typically, what pattern do we get when we confirm hypothyroidism with TSH and free T4?
We have a low free T4 and an elevated TSH.
Perfect. Yeah. So we can do thyroid testing.
Yeah. Taurine testing was the other one.
Perfect.
Is there any point in asking about diet history? Feeding?
Yeah, I think Ingrid said to take a good diet history from the owner.
What would you be looking for there?
So just be seeing if they're on like a standard commercial diet or if they're on some kind of boutique pea legume grain-free kind of diet, in which case I'd be a bit more worried.
Yeah, that's it. There's some sort of relationship with grain-free diets, and we don't know what it is yet.
I have a sort of exam type question.
Yeah.
So, for instance, if you've said I would do a TT4 in your initial diagnostic workup, would you then have to state it again in this question here?
I probably would, only because I probably would say, like Ingrid did, I would, you're still going to get some marks for saying thyroid testing, but just expanding and saying that you understand the difference of how we diagnose hypothyroidism. So do a total T4 and then follow up with TSH and free T4 testing, I think would be the perfect answer. Specifically in the context of this now being a DCM case. In the first part, we didn't know that. And because hypothyroidism can be like a DCM phenotype, so can mimic the disease because our thyroid hormone is so important for normal contractility. I think demonstrating that you understand that excluding hypothyroidism is important in a DCM workup, I would mention it again. Does that make sense? You're not going to lose points for saying things again at all. Yeah. Okay. So we're going to do good diet history from the owner, taurine and L-carnitine blood testing, thyroid testing, we said, and Ingrid, you mentioned a Holter as well, both as part of determining our best treatment and to make sure that the patient isn't having sustained tachycardia at home, which can also worsen DCM. What other things? There's one other thing that we could do that can lead to worsening DCM. I'm being a bit mean because it's not very common. Let's say this patient was also pyrexic with an elevated CRP of 100 on a CRP reference scale of 0 to 10.
I mean, like myocarditis, so testing for troponin.
Yeah, so we could definitely do a troponin as well. Great.
And what about prognosis? Anything you should warn the owner about?
Oh, Jeff, you're jumping ahead.
Oh, yeah, right.
The
Okay.
patient has confirmed stage C dilated cardiomyopathy with pulmonary edema. You perform a Holter ECG with greater than 1,200 VPCs noted in a 24-hour period. Outline a long-term treatment plan for the patient, and what prognosis do you give the owner? So we all know one drug that we're going to need to give this dog at least.
Famobendin.
Perfect.
Potentially some furosemide as well.
Excellent. Yeah.
Just a question about the VPCs.
Yeah.
Would it be reasonable to start treating with Pemabendin first and then see if there's an improvement in the number of VPCs? Because am I right in assuming that the VPCs are, it's an ectopic rhythm that's secondary to the cardiomyopathy. So if you treat the cardiomyopathy first, you should see an improvement in the VPCs, right? Or have I gone
I
down?
love that rationale, but if we think about the pathophysiology of DCM, what's actually happening in the myocardium with DCM?
So it's stretching out essentially. So you are getting enlargement of the chambers without a thickening of the heart muscle. Is that correct?
Yeah, so it's eccentric, so it's just getting bigger. But what's actually happening at a cellular level to the myocardiocytes?
Is it stretching them?
Sort of, but it's replacing them with something else. Does anyone know the pathophysiology of DCM?
Fibrosis?
Yeah, perfect. So your normal, beautiful contractile myocardiocytes are being replaced by fibrous fatty tissue. Okay. So even if we give Pemabendin, like a positive ionotrope, that isn't going to fix the fact that our myocardium is significantly diseased with little pockets of fibrosis.
Okay.
So what's that going to do to our risk of ventricular arrhythmias?
It's going to increase that because we've got a reduction in normal functioning tissue. So we don't have
Perfect. Exactly. And the PIMO isn't actually going to do that. Of course, it's going to help our systolic failure, which is not why he needs it. Our frusamide's going to help with our congestive failure. But with that degree of VPCs, we're still going to need some antiarrhythmic control. But yeah, it's a really good question.
So it's definitely not an escape rhythm then.
Yeah, we're going to assume that no, we're going to assume that it's VPCs from the like altered conductivity.
Okay.
The fibrous heart, yeah. Does that make sense?
Yes, it does. I was just like, I think when it comes to VPCs and also escape rhythms, sometimes I'm a little bit shaky about when to call it.
Yeah, for sure. No, I think if the exam questions kind of state something like that, just assume that's a VPCs. What else might we? So we're going to do Pemabendin, furosemide. What else do we want to do?
Would you do mexiletine?
Yeah, perfect. Or what other drug can you use?
Sotalol.
Perfect. And do you know what class of antiarrhythmics each of those are?
Mexiletine's like a sodium blocker. It's
Yeah.
class 2. And Sotalol is a potassium blocker.
Yeah. Perfect. So mexiletine class 1 sodium, sotalol class 3 potassium blocker. Perfect. There's also some talk, it wouldn't be wrong to say you're going to empirically dose taurine in this patient, even if the taurine level is normal. There is an overrepresentative of Cocker Spaniels that get taurine deficiency and that do seem to have some positive response, even if their blood taurine levels are normal. So some cardiologists will put all patients with DCM, particularly a breed like a Cocker Spaniel, on taurine empirically. So that's also not wrong to say. Great.
Prognosis, is it like 6 to 9 months or something?
Yeah, that's spot on. That's what we say. 6 to 9 months once they're in congestive failure from DCM. So it's a bit sad. What about if the patient was markedly taurine deficient on bloods?
then you're definitely going to taurine supplement and also change the dog's diet.
Yeah.
Mm.
Do you think that might change the prognosis?
They could do better.
Mm. Yeah.
Yeah.
So even 24 months or some longer. Much better, which is good. So it's worth testing for or treating. And what's that one other thing that we should warn the owner about, given that Halter finding?
Sudden cardiac death.
Do you know how likely that is in DCM?
It's pretty likely, like it's pretty high risk.
Yeah. Yeah, perfect. So yeah, high risk of sudden death with that amount of VPCs. Probably over 25%, which is quite high. Great. Okay, cool. Any questions about that? No, all good. The only other things I had written down, which I don't think you'll need for good marks, but just if you're interesting with the, oh, where am I going? Part of the workup, I also had heartworm testing, if you wanted to do that. Great. I always forget about it for any cardiac respiratory case in a dog. It's always worth saying. And in the history, the one other mimicker of DCM that's a bit more unusual, like myocarditis, would be toxicities. So you may have heard of like doxorubicin. So patients that are on chemo protocols, that's why they'll often have a baseline echo to assess their suitability for doxo. So if the owner said, oh yeah, he's actually had multiple rounds of doxorubicin at an oncologist for bonus points, they would be great additional questions to ask. Okay. Happy to move on?
Can I just ask, sort of alluding back to what Elora was saying before, is, like if you do this brain dump and you've said every single test, and then you get that next question a bit later that says, now what next test would you like to do? But you've already listed all of them. You just repeat them. Will they give you any indication that you've actually covered it?
The thing is, though, I don't think you definitely can, but you guys like really working through the problem. So I don't think you would, unless you said, because no one in this test, like we laugh that we just do. Remember last tutorial, we were like, are we just going to say like basal cortisol for absolutely everything? But we didn't in this one. It's actually not.
Yeah, that's true. Yeah.
It's
But I
actually
was thinking like I might have said an echo and all of that.
totally fine. I think if you got
Yeah.
presented with like a limping dog and you're like echo and everything, then maybe. But I don't, in the moment, I honestly think that if you stick to your clinical reasoning of like, what would I do? Like, let's think of my problem list. Even if the question isn't a problem list, you can write down your problem list next to you. I find that so helpful. Number 1, tachypnea. Number 2, tachycardia. It sounds so simple, but then you can just go back to your good, solid clinical reasoning of what initial tests you would do. And yes, if you listed everything under the sun, like an echo and a limping dog, you might then have to go back because you've listed everything. But I honestly don't think you will in the moment.
That's awesome. Thank you.
Just use your clinical reasoning of like, what's reasonable right now for diagnostics, and then they'll guide you. Like the DCM and these further tests, you probably aren't going to say taurine in the last question or a Holter, but then you've been guided to say those, if that makes sense.
Okay, so if we don't mention them in the first initial diagnostic test, you can still get the marks in the second part.
Yeah, because saying in this which initial diagnostic test you wish to perform in this dog, if you saying a Holter ECG here isn't wrong, but you're probably not going to say that, so that's probably not going to be on the mark scheme. Saying taurine here isn't wrong, but you're probably not going to say that, so it's not going to be on the mark scheme. So then when we know it's DCM, saying those more specific things are where you're going to.
So say if we did just have a brain fart or something and we got to this part of the question and it says, oh, we've confirmed DCM. And then you're like, oh, I would have done an echo for that. So you didn't mention echo. I mean, it seems like they've given you the answer that you know that they confirmed that with an echo. Can you say echo, even if they say like I've done an echo now and it's DCM? Like you wouldn't get the mark, would you? Because you should have said it earlier.
This question, because I've said as part of the workup you perform an echocardiogram and what further diagnostic tests. Now I don't think echo would get you a mark, but you don't need to get 100% of everything on the mark scheme to get a great result. So even if you haven't said echo here, it really, really doesn't matter. You can still pass this question really well. And I specifically didn't put a murmur in, which was a bit mean, but we see DCM dogs without murmurs, which can be quite confusing.
Cool. Thank you.
So yeah, don't panic if you haven't said a test and then they're like, here's the echo. And you're like, oh, I didn't do that. Doesn't matter. You can still get a great answer.
As I said before we started, certainly don't panic. You're in charge. Remember, you're going to beat them. They're not going to catch you.
Okay, I'm sorry, I'm so I haven't been as fast today, so we might not get through all four, but that's okay. I can always send them to anyone if you want to. Let's just have a little look at this in our first, just in our last little bit of time. An 8-month-old male entire Yorkshire Terrier presents for hematuria and plaquuria. You know the patient has gained weight poorly and is underweight for a puppy. The owner mentions they're not sure if he likes his food, as after eating, he has occasionally been standing with his head pressed against the wall. On questioning, the owner reports he drinks much more than their adult dog. He is quiet, underweight, rest rate 20, heart rate 120, temperature 38.5, a small non-painful bladder. What are your differential diagnoses for hematuria in this patient? And what is your leading differential in the context of this case?
Mine would be uroliths, urinary tract infection,
Great.
prostatitis,
Right.
neoplasia you can put on the list, but it's going to be lower down. And my leading differential will be uroliths, because this puppy probably has a portosystemic shunt.
Yeah, you're thinking.
What type of uroliths would we expect?
Urate stone.
Ammonium urate, perfect. Any other differentials we want to say?
Coagulopathy.
Oh, did someone just say coagulopathy?
Possible, yeah.
Yeah, love it. Yeah, definitely. I think it's great. Puppies love eating rat bait. Why not? Perfect. Coagulopathy?
You're like a
Did you have-
renal hematuria.
Yeah.
Yeah.
Something upper urinary tract, I think, is worth including. A renal hematuria, a pyelonephritis, a ureteral calculi. So upper. Perfect.
Remember, coagulopathy is going to be an acute thing, whereas this is a chronic problem.
That's true. Although I was a bit mean, and the question is, what are the differential diagnoses for hematuria in this patient? So I guess you could have a comorbidity. I don't think they'd be that mean in an exam, but
You could certainly say a coagulopathy, but that should be acute, and this appears to be chronic. And just say that,
Yeah, perfect. You perform baseline bloods and urinalysis, and below are the results. So we've got a low urea, low albumin, a glucose which is low end of normal but within the reference range, low cholesterol, ALT is normal, 95, upper reference range 100, ALP is elevated, 180, upper reference range 90. We've got a mildly decreased mean cell volume of our red blood cell count, but our hematocrit is normal. And USG 1018 with ammonium biurate crystals on cytology. Does this support your leading differential, and which further confirmatory tests would you recommend?
Yeah, you've got a reduction of liver products, which suggests liver dysfunction. Therefore, the next test I would do would be paired serum bile acids.
Perfect.
Would you have to extend on your explanation a little bit more if it's just asking for that?
No. If you said that congenital portosystemic shunt is your leading differential, is there anything else anyone would like to do? That's a great answer.
You could do an ammonia level because the dog's head pressing. To look for hepatic encephalopathy. You could do imaging, so ultrasound or a contrast CT would be better.
Perfect.
Abdominal.
A CT angiogram confirms a single extrahepatic portosystemic shunt and the owner is referred. Outline a medical stabilization for this patient. Say this patient can't get into a surgeon for a week or 2 weeks. What do you think we should do in the meantime?
So if the dog has high ammonia levels, I put it on a hepatic diet. I put it on lactulose. And
can you extend on the hepatic diet? If the owner says, what does that mean? What should I be looking for in a diet?
So it has a like it's still got like it still meets the minimum protein requirements, but it is lower and it's a moderate it's modified. So usually it's a higher quality protein source. They might use like a vegetarian protein source because it's metabolized like broken digested better. So like soy protein. I think it's higher in fiber, I think as well. What else?
I read somewhere that in terms of the protein content, there's not a lot of evidence to actually put them on a reduced amount of protein. It should be appropriate to life stage. So in this case, is it better to have them on a moderate level protein so that they're then not going into protein catabolism?
Yeah, absolutely. So like Ingrid said, we don't really do extreme low protein diets anymore. It would be classed as moderate protein. And like Ingrid said, vegetarian proteins like soy and dairy produce less ammonia per gram during digestion. So you can keep them on the same moderate amount of protein for their life stage with reduced ammonia. So the hepatic diets are often dairy or soy based, or if a nutritionist is formulating one. And they've also got zinc and antioxidants and things like that in, higher fiber, higher carb to get the calories in. Perfect. And why would we put the patient on lactulose? What's the mechanism of action of that helping?
So it's oh no, you can go in.
Go for it.
Okay. Jump in at any point. So it is a fermentable or soluble fiber and it acts as ammonium sink and it speeds up colonic transit time, meaning there's less time for bacteria to ferment the colonic material and produce ammonia. And also it promotes incorporation of ammonia into the bacterial cell wall. Is that correct?
Yeah, that's so interesting. I didn't know it goes into the bacterial cell wall. Yeah, it acidifies the colon, so it can donate a hydrogen ion to ammonia, NH3, to be NH4 plus, and then it's trapped as an ammonium ion, which can't be absorbed into systemic circulation. So maybe it's because it's trapped in the bacteria. That's so interesting.
Yeah, I think it's, I can't remember where I read it.
Perfect, but that mechanism is perfect.
Yeah.
It acidifies, it donates its hydrogen, traps ammonia as ammonium ions, which can't be absorbed, decreases transit time. Perfect. Sorry, I know I'm rushing. Any other medications apart from we're going to do the diet and the lactulose? Is there anything else that we might want to give this pup?
Antibiotics, usually like amoxicillin or ampicillin, just to decrease the bacterial population that's producing the ammonia.
Yeah. Which class of bacteria typically produce the ammonia?
The anaerobic bacteria?
Perfect. Yeah. Yeah.
Could you go for metronidazole?
You can, but it's just what's the downside of metronidazole? It's good because it's
hepatically metabolized.
perfect, yeah. So they can get neurotoxicity with it, even though it would be a good narrow spectrum choice. Some specialists won't use antibiotics before, but it's interesting when we said in the differentials that a UTI was also a differential. A lot of these pups have active UTIs, so when we do a culture, they end up being on antibiotics anyway. So, and the other thing potentially before surgery would be vitamin K with liver disease. Yeah, perfect.
There was I don't know whether it's still done, but iovone enemas were used at one stage in the very acute ones.
Yeah. Yeah, like really acute encephalopathies. Sorry to rush, guys. I can email anyone any more example cases. I'm sure that your brains might have had enough by now anyway. And hopefully you can just have a nice day doing nice things for your brains and for your bodies today to get ready for your orals. And good luck, everyone. We'll be thinking of you. We're going to skip next Monday just to give you all a break. And Anna and I will see you in 2 weeks from Monday.
Can I ask a really quick question?
Yeah, go for it.
Oh, okay, cool.
Sorry.
No, that's okay. It's just more about exam questions.
Okay.
I remember I mean Mentor saying is that they can basically give you a technique and ask you to describe how to do it. Is that
Yeah.
likely to happen?
Yeah. So, I mean, it's going to be something reasonable. So, like a CSF, a joint tap, maybe draining a pericardial effusion. Is there any in particular that you're worried about?
I think it's mainly just the ones that I haven't done. Yeah, which is a few, but that's okay. I can
You've
revise
got
them.
the membership guidelines from the website, from the college website, because it's got a little list of procedures that they list out some. So those ones would be the ones that would be worth just going over and just making sure that you've got especially things that you might not know off the top of your head if you're not, done a lot, that those little ones might be worth going over. Yeah.
Okay. Thank you. Thank
Cool.
you
I
for the
missed
tutorial.
earlier what the other etiology was for year 8.
Oh, we didn't get it. Does anyone want to say before we head off?
Primary hyperuricosuria, like the genetic one that English bulldogs like to get.
But there's a few Dalmatians.
Dalmatian, sorry. I knew I was like, there's another major breed.
Bulldogs too, yeah. And Aussie Shepherds. Yeah, there's bulldogs too. Okay, awesome. I've got to run, guys, but we will see you all soon. Good luck, everyone.
Can you
Thank
email
you.
me the how do I contact you? I'm not actually sure how to contact you.
Sure. I'll be able to get your email, Ingrid.
Okay.
If you do want to email me though at all about anything for the exams, it's just helen@vetsnorth.com.au.
Could you
Thank you.
send the other cases as well
Yeah.
to me? That would be great.
Please.
Thank
I
you.
really appreciate that too.
Thank you. Thanks.
Good luck,
Yeah.
guys. Have a great day.
Thank
Helen,
you. Bye.
Helen, before you go,
Yeah.
you're nearly there as far as the fellowship's concerned.
Oh,
You might as well do it.
thank
I
you.
was just thinking there's a coincidence. So there's 227s in my phone number. That would be a good year for you to do it.
Oh, really?
Oh, yes.
I don't think I'd be ready.
I'll bet you will be.
It's very kind to think that.
I've every faith in you. Go for it.
Take care. Have a great day. See you, Jeff. Bye.